Okay, let's unpack this. Think about the families in your life, your own, maybe your friends, the ones you've seen in clinicals. They're more than just, a group of people sharing a roof. They're these incredibly intricate, dynamic systems that fundamentally shape who we are. Today, we're taking a deep dive into the heart of family interventions within psychiatric nursing. We're pulling insights directly from Varkarollis's Foundations of Psychiatric-Mental Health Nursing, 8th edition. And our mission really is to equip you with the essential knowledge, things like healthy and dysfunctional family patterns, the crucial assessment tools, and the nursing interventions you'll actually use to support patients and their families effectively.
Yeah, and what's really fascinating here is that understanding these family structures, these functions, it isn't just theory you memorize. Not at all. It's a vital diagnostic and intervention tool, something you'll use every day in clinical practice. It helps you understand your patient's unique context, and honestly, it's absolutely crucial for excelling on exams like the NCLEX. It prepares you to provide truly holistic, patient-centered care.
That's right. And to bring this to life a bit, let's think about a family you might encounter. Like, imagine the Smiths. Kate, she's 17, dealing with depression, maybe some marijuana use. Her parents, Hank and Catherine, they're divorced, and there's still a lot of, well, unspoken tension there. How Kate functions, her symptoms even, often makes so much more sense when you see them within the context of their family system.
Precisely. And that starts with how we even define family in the first place. Way back, like in 1957, Duvall's initial concept focused almost exclusively on the nuclear family, mom, dad, kids. But if we connect this to the bigger picture today,
Hmm.
well, today's understanding has evolved dramatically.
It certainly has. Sutherland, back in 2014, identified so many more diverse structures that are common in the U.S. now. I mean, beyond the traditional nuclear family, we see single-parent families, obviously. Then there are unmarried biological or adoptive families. That's two unmarried parents with their kids. Right.
Absolutely. And recognizing these diverse structures is so key for culturally competent care. You just can't apply a single-family model to everyone anymore. We also see blended families, where children live with one biological parent and that parent's spouse. Step families, basically.
And what about cohabitating families? Is that different?
Yeah, slightly different definition. That's where children live with one biological parent and that parent's unmarried partner. Then you have extended families, children living with a parent, and at least one related non-parent adult, like a grandparent or an aunt living in the home. And finally, this other category, which can include things like foster families or even children living solely with their grandparents. This whole broadening idea of what makes a family fundamentally changes how we approach interventions. It ensures we meet families where they actually are.
Okay, so regardless of the specific structure, what defines a healthy family? Like, what are those core functions they perform?
Excellent question. Healthy families essentially provide their members with the tools for effective interaction, both within the family unit and, with society at large. There are basically 5 core functions we look at.
All right, let's break those down. The first one is management. This sounds like it's all about decision making. Who holds power, how resources like money and time get allocated, what the rules are, that kind of thing. So for the Smiths, even though Hank and Catherine are divorced, they still need to somehow agree on decisions about Kate and Jennifer, like school or healthcare.
Exactly. In healthy families, the adults generally agree mutually on these big things. But in dysfunctional families, you might see someone inappropriate, maybe even a child, forced into making adult management decisions. Imagine like a 12-year-old having to decide between paying the electric bill or buying groceries. That's a huge red flag. It indicates a breakdown in management, putting terrible stress on a child.
Wow, yeah. Okay, next function, boundaries. This is how families maintain distinctions between individuals and the family unit as a whole. Minuchin identified 3 types, right? The first is clear boundaries. These are the healthy ones. Adaptive, firm, but flexible.
That's right. Clear boundaries are adaptive and healthy. They're firm enough to provide structure, but flexible enough to allow for change and individual growth. Roles are appropriate. Think of boundaries as the family's immune system. Clear boundaries mean a healthy, resilient system.
Okay, and then the unhealthy ones.
Well, you have diffuse boundaries. These are unclear, fuzzy. They lead to a lack of independence. Individuals really struggle to define themselves, leading to what we call enmeshment, this over-involvement where people can't truly separate their own identity from the families. Nobody's really in charge. It discourages differentiation, which is having a strong sense of self while staying connected. This can manifest as like suppressed feelings or even psychosomatic symptoms where emotional stress shows up physically.
Yeah, I can see how that would be critical, especially for someone like Kate feeling caught maybe between her parents' tension and the other extreme, rigid boundaries.
Exactly, the opposite of diffuse. These involve really strict adherence to rules and roles. It results in disengagement and isolation. Communication is minimal. Family members rarely share thoughts or feelings openly. It makes intimacy and bonding incredibly difficult. People feel very alone within the family.
Okay, third function, communication. This seems straightforward, but I bet it's complex.
It is. In healthy families, messages are generally clear, comprehensible. People use I statements, like "I feel frustrated when," rather than blaming. There's open expression of thoughts and feelings. And while parents typically lead, children's opinions are still heard. There's a natural, necessary hierarchy.
But in dysfunctional families, this is where it gets really interesting, right? Like how these patterns play out, maybe even in a hospital setting when you're talking to a family. A nurse needs to spot these quickly.
Absolutely. Dysfunctional communication patterns are often the clearest symptoms of deeper issues. Spotting them is key. For example, you might see manipulating. That's making indirect requests, like a child starting a fight just to get attention, or saying, if you clean my room, I won't tell dad about whatever.
Uh-huh. Or using guilt trips.
Exactly. Another pattern is distracting, introducing irrelevant details to avoid conflict, changing the subject constantly, or generalizing, using words like always and never. Harry is always angry. Instead of exploring specifics, it just shuts down conversation. Then there's blaming, deflecting focus onto others. And placating, pretending to be well-meaning just to keep the peace, avoid conflict at all costs. Like, don't yell at the children, dear, I put the shoes away. When that wasn't the issue at all. Recognizing these patterns, crucial for effective intervention.
Okay, the fourth core function is emotional support. How needs get met, basically.
Yeah, how affection is shown, how conflict is handled, how needs are met. In healthy families, affection is really paramount. Anger happens, sure, but it's usually short-term. It doesn't dominate interactions. Emotional and physical needs are generally met, which fosters growth.
But dysfunctional families.
They're often dominated by conflict and anger. It
Oh.
leads to isolation, fear, or emotional impairment. Members feel unsupported. They can't really grow emotionally. This might be where Kate's family struggles, right? If her parents' unresolved issues overshadow their ability to provide consistent emotional safety for her and her sister.
Makes sense. And the last one, number 5, socialization.
Right. This is where individuals first learn social skills, how to interact outside the family, how to negotiate for personal needs. Children learn mainly through role modeling from parents. And healthy families show flexibility in adapting to new roles during different life stages, like when kids leave home, or maybe when aging parents need help from their adult children.
Those transitions sound like stress points.
They absolutely are. Periods of change definitely increase overall family stress. Now, if the family is socialized to manage stress through open, direct communication, that period might be relatively short-lived. But if they're not, if they use those dysfunctional patterns we talked about, that stress can linger and really deteriorate the family's ability to function.
Okay, so with that foundation, the different structures, those 5 core functions, let's zoom out a bit. Let's look at some broader concepts that often come up in family therapy or when you're assessing a family. First, the identified patient. This sounds important.
It is. This is the individual the family perceives as the problem, the symptom bearer, the one whose issues seem to demand fixing. For the Smiths, Kate, with her depression and marijuana use, is clearly the identified patient in their eyes.
But it's not always that simple, is it?
Not at all. From a therapeutic viewpoint, while this person certainly has issues, their symptoms can also serve a function in the family system, like diverting attention away from deeper hidden family problems. The identified patient's issues might even, paradoxically, stabilize the system in the short term. Think about adult children who don't launch, who stay home, maybe sacrificing their own future plans, partly to keep their conflicted parents together. It's a violation of healthy roles, but it serves a purpose, however unhealthy.
Wow. And this often ties into something called family triangles, right? These common dysfunctional patterns.
Exactly. When tension builds between two people a dyad and communication breaks down, that tension often gets routed through a third person. This forces the third person into the triangle, and communication becomes indirect. It acts almost like a pressure valve for the original pair, but it puts the third person in a really difficult spot.
Can you give an example?
Sure, think about Lisa's family. Lisa's the youngest. She senses this growing tension between her parents, Susan and Bill. When things get really bad, Susan starts venting her frustrations about Bill to Lisa, even confides about Bill having an affair. Lisa gets so scared her parents will divorce when she leaves for college that she starts thinking about ditching her dream university for a local community college just to stay close, to maybe hold things together. So this triangle, while destructive long-term for Lisa, temporarily stabilizes Susan and Bill's relationship by diverting their tension through her.
That's a powerful and sad illustration, how a child's well-being can get sacrificed just to maintain this unhealthy balance. There was another vignette, Addison's family.
Right. Addison is 6, having trouble making friends. Her mom, Megan, is really overprotective, which actually makes it worse. Megan thinks her husband, Sean, is uncaring. He thinks she's too uptight. They haven't been intimate in a year, and they're both angry about his travel schedule and issues with his parents.
But they don't talk about that stuff.
No, neither Megan nor Sean addresses their marital issues directly. Instead, all that anger and tension gets played out in the parental arena. They constantly battle over how to handle Addison's social isolation. So Addison's symptoms, her difficulty making friends, actually reflect their unaddressed parental conflict. And for you, as a future nurse, recognizing this is vital. You absolutely have to avoid being triangulated into these patient-family systems. Like, if a family member pulls you aside to complain about another family member or tries to get you to take sides, you have to maintain boundaries and encourage direct communication between them. That's the key.
Speaking of key terms, there were a few more from family dynamics. Differentiation.
Yeah, differentiation is basically the ability to develop a strong sense of self, your own identity, while still maintaining an emotional connection with your family of origin. It's about being your own person and connected, not having to choose one or the other. Healthy families support this.
Okay. And a double bind. That sounds unpleasant.
It is. It's a real no-win situation. You get contradictory messages. Usually a positive command may be spoken, followed by a negative one, often nonverbal. It leaves the person feeling confused, trapped, and criticized, no matter what they do. Like, imagine a parent saying stiffly, "What? No hug for your mom." But when you go to hug them, they stiffen up, maybe pull back slightly, and then say, "See? You only care about yourself. You're kind of damned if you do, damned if you don't."
Yikes. Okay, then scapegoating.
Scapegoating is a form of displacement. One family member, usually the one with the least power, gets blamed for another member's distress or for the family's overall problems. The real purpose is to deflect focus away from the blamer's own painful issues. You often see parents blaming a child for marital problems, for instance.
Got it. And finally, sociocultural context.
This is just the essential framework for viewing the family. It means considering how factors like gender, race, ethnicity, religion, economic class, sexual orientation, how all these things influence the family's dynamics, their beliefs, their experiences, and how we understand them. It's absolutely crucial for providing truly patient-centered, culturally competent care. You can't ignore this context.
Okay, so we've unpacked these really vital theoretical concepts. Now, the next logical step is to see how nurses actually translate this knowledge into concrete action. Let's dive into the nursing process as it applies to family interventions, starting, of course, with assessment.
Right. The main purpose here is to really understand how the family functions and how individual members perceive things like communication and emotional issues within the family.
And one key tool for this is the genogram, right? Developed by Bowen.
Yes, exactly. A genogram is an incredibly efficient and insightful clinical summary. It visually maps out a family's structure, relationships, and even significant events across at least 3 generations.
So it's like a family tree, but with much more detail.
Way more detail. Females are circles, males are squares. Lines show relationships a solid line for marriage, maybe slash marks for separation or divorce, lines connecting parents to children. But crucially, you add demographic data where they live, occupations, education levels, and you go deeper.
Yeah.
You record functional information, medical history, emotional issues, behavioral patterns. You know critical life events, births, deaths, major illnesses, job changes, moves, divorces. It creates this rich snapshot of their past and present functioning that often reveals important intergenerational patterns.
Okay, let's verbally walk through Kate Smith's genogram again, the one we mentioned earlier. Imagine you're looking at this diagram. You see Kate, 17, our identified patient, circle, noted with depression, marijuana use. Below her, her sister Jennifer, 14, circle, marked as healthy. Above them, their parents. Hank, square, 43, college-educated, history of major depressive disorder. Catherine, circle, 35, college-educated, generalized anxiety disorder. A line between them with 2 slash marks indicates they're divorced.
You go up another generation. For Hank, you see his father, Henry, square, died of heart attack, MI at 43. Which is Hank's current age.
Yeah.
That's significant. Hank's mother, Cindy, circle 65, has COPD. On Catherine's side, her mother, Sylvia, died by suicide at 47 after breast cancer.
Oh.
Big red flag. The family never discusses this. Unresolved grief, potential trauma. Catherine also has a brother, Mike, square 38, noted as drinks too much, didn't finish high school. And you might even note if there were miscarriages. Catherine's mother miscarried a female fetus before Catherine was born. Sometimes that sets up certain expectations for the child who was born.
And the relationship lines tell a story, too. You draw lines showing, say, Kate has a very conflicted relationship with her mother, maybe a squiggly line there, while Jennifer is very close with her father, perhaps a thicker, solid line. And you might note that Kate often acts as a go-between, running interference between her parents, trying to shield Jennifer from their arguments. She's triangulated.
Spot on. And this raises that important question again. How does seeing this whole three-generational picture help you understand Kate's current symptoms? It suggests potential intergenerational patterns, right? You see depression, anxiety, substance use, unresolved grief, communication issues crossing generations. This holistic view guides your assessment and intervention planning. You see beyond just Kate's individual symptoms to the underlying family dynamics influencing her.
That makes so much sense. And there's a critical ethical piece here for nurses, too. Self-assessment.
Absolutely essential. You're going to interact with all kinds of patients and families. And because no family is perfect, you will encounter dynamics that resonate with your own background, maybe trigger uncomfortable feelings. Nurses have to be aware of their own family histories, their own biases, their own potential reactions. We call this potential for over-identifying or reacting emotionally countertransference.
And you mentioned being pulled into triangles.
Yes, you can easily become triangulated into a patient's family system if you're not careful. Like if a patient starts venting to you about their spouse, instead of talking directly to them. Or if a family member tries to get you on their side against another member. A key sign this might be happening. If you feel an unusually high level of anxiety yourself, more than the situation seems to warrant, that's often a clue you're getting drawn in. The antidote is maintaining clear boundaries yourself and always encouraging direct communication within the family. It ensures your interactions remain therapeutic.
Okay, so after that thorough assessment, including the genogram and self-assessment, you move to nursing diagnosis. These are the NANDA-approved labels, right? Standardized ways to state the problems or risks.
Exactly. NANDA stands for the North American Nursing Diagnosis Association. These diagnoses help you clearly articulate the family's health status and needs based on your assessment data. Examples relevant to families could be things like risk for caregiver rule strain, dysfunctional family processes, impaired family resilience, or ineffective family health management. There are many possibilities listed in resources like Varkarola's Box 35.3.
Then comes outcomes identification. What are we hoping to achieve?
This needs to be a collaborative process with the patient and the family. You work with them to set realistic goals. As nurses, our aim is generally to reinforce their strength, help them identify and use resources, both internal and external, and strengthen their coping skills. Key outcomes might include things like the family being better able to accept the reality of the illness, learning to deal with specific symptoms like hallucinations or poor hygiene, understanding medications effects, risks, benefits, accessing community support, and feeling less anxious and more in control.
And when it comes to planning?
The absolute top priority is always safety. You have to address any immediate risks. Is there aggression? Suicidal behavior. Signs of abuse. Depending on the situation, this might mean involving protective services for an abused child or elder, or facilitating hospitalization for someone who is acutely suicidal. Safety first. Beyond immediate safety, nurses play a crucial role in planning education to help families cope with the current crisis and improve their overall quality of life long term.
Okay, let's talk intervention. What can generalist nurses do?
Generalist nurses play a really vital role. You can provide counseling using a basic problem-solving approach for immediate family conflicts or issues. This requires developing really effective listening skills and approaching all family members in a consistently non-judgmental way. That builds trust.
And we should be watching for signs of stress.
Definitely. Be alert for those stress cues within the family system. Things like, are they unable to understand or follow through on treatment recommendations? Are members reporting lots of physical complaints, somatic symptoms? Is there pervasive high anxiety, depression, or anger? Are there new problems at school or work? Is substance use increasing? These are all signs the family system is under strain.
Communication style is key here too, right?
Absolutely. Prioritize collaborative communication. Instead of a closed-ended question that might feel like an accusation like, do you think you will help your mother take her medications? Which can put someone on the defensive. Try an open-ended approach. Tell me your thoughts about the medication your mother has been prescribed. It invites their perspective. It sets a collaborative tone. And make sure you elicit and really listen to the perspective of each family member. Often they might be hearing each other's views clearly for the first time in these conversations facilitated by you.
A huge part of intervention, especially with serious mental illness, is family psychoeducation, isn't it?
Yes, it's incredibly important. The primary goal is sharing mental health care information clearly and supportively. This is vital for families dealing with something like schizophrenia, for example. It helps them understand the illness, the symptoms, including those subtle early warning signs, the prodromal symptoms. It helps them understand medications, manage side effects, and it also provides a safe space for them to share really difficult feelings: anger, loss, the burden of stigma, helplessness. It validates their experience. Psychoeducation is also used very successfully in things like parent management training programs.
And what about interventions done by advanced practice nurses?
Psychiatric mental health advanced practice registered nurses, APRNs, can conduct formal family therapy. Their goals are usually broader and deeper: reducing dysfunctional behaviors within the family, helping resolve internal conflicts, mobilizing family resources, improving communication patterns overall, increasing sensitivity to each other's emotional needs, strengthening coping strategies, helping the family integrate better into societal systems like schools or workplaces, and ultimately promoting the individual psychosocial development of each member.
Are there times when family therapy isn't the right approach?
Yes, there are contraindications. For example, if the home environment isn't safe, if there's an immediate risk of harm to someone, or if anxiety or hostility levels are just too high and uncontrolled for productive work, or if there's significant dishonesty among key members. Also, if the core parental conflict revolves around sensitive sexuality issues, that's often better addressed in specific couples counseling first, rather than in front of the whole family.
Okay. But generally, it's a powerful tool.
Immensely powerful. And it's often combined with psychopharmacology, especially for disorders like bipolar disorder, major depression, or schizophrenia. It's also worth noting that less intensive options like psychoeducational family therapy groups or even self-help groups like NAMI, National Alliance on Mental Illness, family support groups, are also incredibly valuable and often more accessible.
Great. And finally, we circle back to evaluation. How do we know if our interventions worked?
As generalist nurses, you'll primarily evaluate things like, does the family understand the therapeutic regimen better? Can they access outside support now? Have their coping skills measurably improved? Are they communicating more effectively around the illness?
And for the advanced practice nurse doing family therapy?
Evaluation delves deeper. They're looking at the functioning of individuals and the family as a group. Have specific conflicts been reduced or resolved? Have communication skills improved across the board? Are coping methods stronger and more adaptive? Are family members better integrated into their broader social systems? It's a more comprehensive assessment of systemic change.
So what does this all really mean for you, listening, as a future nurse? It means learning to see beyond the individual patient sitting in front of you, to see the whole family system they're embedded in. It means recognizing that Kate Smith's depression isn't just hers. It's intertwined with the intricate dance of her parents' divorce, maybe her grandmother's unspoken suicide, the patterns of anxiety and substance use, the communication styles passed down through generations.
Yeah, and this brings up a really important question for you to think about as you move forward. How might recognizing something like a double-bind communication pattern or spotting a family triangle during your assessment, how might that lead you to a completely different and ultimately much more effective intervention strategy for a patient like Kate? Understanding these dynamics, it fundamentally changes your approach. It allows you to empower not just the individual, but the entire family unit, fostering real, sustainable healing.
We really hope this deep dive into family interventions has given you a clearer roadmap for your nursing journey. You're now equipped with insights into defining family, understanding its functions and patterns, assessing it with tools like genograms, and applying the nursing process to support that holistic well-being. This knowledge is truly invaluable, not just for doing well on the NCLEX, but more importantly for becoming the compassionate, insightful, and effective mental health professional you aspire to be.
Thank you so much for joining us on the deep dive. Remember, as future mental health professionals, you are building both crucial knowledge and essential empathy with every single concept you master. Keep learning and keep caring.